And welcome everyone to the development and analysis of human movement. And today we will be discussing the shoulder. The objectives today will be to obtain a general overview of the bony anatomy of the shoulder. We're going to understand the important bony landmarks of the shoulder and identify motions of the shoulder, along with developing, once we hit lab, developing a comfort with palpating gross anatomy of the shoulder. This portion that we're going to go over right now will just cover the bony structures of the shoulder, and then we will have a future video discussing the muscular and soft tissue of the shoulder. So, the shoulder complex starts with the scapula. The scapula is a triangular bone located in the posterior superior aspect of the thoracic cavity and articulates through a gliding motion with the thorax. It attaches to the body via a ligament to the clavicle and also through soft tissue muscles as well. It rests between the seventh and the second ribs, and from about 2 to 3 inches lateral to the spinal column. The spine of the scapula rests at around T3 to T4, and what that means is the thoracic third vertebrae and the thoracic fourth vertebrae. We also have the clavicle, which is an S-shaped bone that connects the upper extremity to the axial skeleton on the anterior portion. And then the axial skeleton is the skull, the spinal column, and the rib cage, just a reminder. The sternum is a flat bone located in the center of the anterior thorax, and it has 3 parts: the manubrium, the body, and the xiphoid process. Okay, so if we look over here at our left, we will see the bony portions of the scapula. So you see this long horizontal piece here. This is what we call the spine of the scapula there. It's the most prominent piece. When you throw your hand over your shoulder, you can feel it. For me, mine is about right there. Okay? And there's usually soft tissue right on top, and then there's soft tissue on the bottom, so you can't really feel these. The next palpable structures are the medial border right here of the scapula, along with the inferior angle of the scapula. And we'll get good at palpating that when we get to lab, and I'll teach you guys how to actually find those identifiers and feel those. Then you have the acromion on the top. That's part of the scapula, and you can feel that right here. That's the bony piece, that flat piece of your shoulder right there. Okay? Then you have your clavicle that runs from right here, the SC joint, the sternoclavicular joint. If you're thin enough, I'm not, you can see 2 little, I'm trying to get it out, little bumps right there. And that's where they start, and then they run up in an S-shaped to the acromion, and they connect right here. You can feel a little bump from that flat acromion to the bump of that scapula, or the clavicle right there. Then as you run that back towards the middle, you'll feel another bump, and that's where the clavicle and the sternum meet, right at that manubrium at the top. Then you have the body right here, and then right underneath, right here, is our xiphoid process. Don't push on that too hard, because that is actually a more fragile piece of bone. So let's actually take a look real quick at our 3D model. So if we look at our model, we can see our clavicle and our sternum right here. So this is our manubrium, the body of that sternum, and then our little xiphoid process right at the bottom. So you can follow your ribs up as they come to that xiphoid process, and you feel that little protuberance coming down like that. Okay, then you can kind of feel up on that body of that sternum, and then the manubrium up top. And you see the little grooves of the manubrium right there, and the clavicle sits right inside that, right there. So you can see how it articulates that concave, convex articulation, right? as that attaches there. Then we can follow that. So we come over, and now we have our articulation with our acromion, right? And you can see it's again a concave convex articulation. Sorry, let me get a good view here. I'm going to be too close. Move over. Oh, sorry guys. There we go. Sorry. So you can see right here that concave convex articulation of the clavicle and the acromion here as it comes over, and then we have the scapula on the back, right? So we have the spine of the scapula here, the inferior angle down here, the medial border there, and you can see as I adjust the angle here how that kind of floats. Look here on this side, you see how there's just space there. The soft tissue is what holds the scapula onto the thorax there. So you see there's no soft tissue, and it's designed to be highly mobile. And then lastly, I want to show you in here the anterior portion, the anterior view, because what we're going to talk about in a second is the glenoid fossa here and the humeral head, right? And how they actually articulate with each other. Okay? So as we go back to our PowerPoint, we look at the humerus. And the humerus is the longest and largest bone in the upper extremity. And it has a humeral head that articulates with the glenoid fossa of the scapula. So just what I just showed you guys. The rib cage attaches at the sternum to the vertebral column. It protects the heart, lungs, aorta, thymus gland, trachea, esophagus, lymph nodes, and it's created with 12 ribs on each side divided by the sternum. You have 7 upper ribs, which are our true ribs. Then you have 2 or 3 floating ribs typically, and they attach directly to the sternum via the costal cartilage of the 7th rib. And then our 11th and 12th ribs are floating ribs, so they don't actually attach in the front there. So that's what that means by floating. So let's take a look again at our man here. Or this is actually a woman, sorry. Okay, so we count here. Our 1st, 2nd, 3rd, 4th, 5th, 6th, and 7th are our true ribs, right? Then we have 8, 9, and 10, these last little ones down here, that are our floating ribs. 1, 2, 3. And then we have our 11th and 12th, which are full-on floating ribs. And that's because they don't attach through this fibrocartilage right here. This white is fibrocartilage. And these 11th and 12th ribs don't actually do that. You see that they just kind of hang in there. Okay? So joints of the shoulder complex. Oh yeah, I'm sorry. I wanted to show you this too. Just go back up so you see how long this humerus is here, and it attaches, more sits than attaches on the glenoid fossa in that shoulder. And it just kind of sits like a golf ball on a golf tee. Okay? We have 4 joints within the shoulder complex. The scapulothoracic, that's this right here. That's, as it sounds, the scapula and the thorax. So that's right here, this joint that floats. They call that the scapulothoracic joint. Okay. We have the sternoclavicular joint, and that is this here, where the sternum and the clavicle attach right there. You see that there's space when we look at it through the bony articulation. There's a little disc in there as well, a little fibrocartilage disc, kind of like in our vertebrae back here, and that helps soften that articulation. We have the acromioclavicular, right? So our acromio, right? Acromion. and our clavicular, our clavicle. So this joint here, this articulation often has a disc as well within that. And then lastly is our glenohumeral. So our glenoid of our scapula and our humeral of our humerus, the head of our humerus. So this is the fourth articulation right there. Movement of the shoulder is created through a joint effort of all of these. So as one joint moves, the other does. You can really see that if you think of like levers, right? You think of a lever system. If I move this up, right? If we think of our concave convex rule, what's going to happen down here? This is going to move down, right? Up, this moves down as this moves, and vice versa. As this depresses, this elevates. And then that'll change the articulation here. So you can kind of see that concave convex rule in live action right there. So as we look at the first articulation, excuse me, let's look at the scapulothoracic joint. Okay, it's a non-union between bones, so it's actually one of the more unique articulations within the body because it's not actual bone on bone, so it's not a true joint. It has a concave anterior surface that allows the convex thoracic cavity to have that concave convex rule and kind of slide over itself. It's stabilized through the clavicle and then supporting muscles as well. The scapula rests on the serratus anterior and the subscapularis, and a total of 17 muscles actually attached to the scapula. You can see here the motions of it. We have elevation and depression, and that is about 30 degrees of movement. We have protraction and retraction, which is 30 to 50 degrees of movement. Okay, then you have up and down rotation, about 60 degrees, right? So our rotation here is 60 degrees. And then, as we said, the protraction and retraction, which is also AD and abduction, because as we retract, we pull our shoulder blades closer to midline, right, for our adduction. And then as we protract, push forward like that, we get our abduction. Okay, and that's about 30 to 50 degrees, depending on how strong the muscles are on the back end and everything like that. The scapula allows for increased range of motion beyond what the glenohumeral joint alone can create. The scapula will elevate 1 degree for every 2 degrees of glenohumeral elevation. So you see here, let's look at our scapula. We can look at the anterior portion here. Okay, and you can see how it is very convex here. Sorry, concave. It's curved in so that it rides on this convex rib back here, and then we have soft tissue underneath it as well. Okay, so that's our scapula there. You can see how right there, you can really see how it just glides over the muscles that would be there. And then you see here that these ridges really just create a nice belly for all those muscles to attach to sit in, and it just glides over, acting as a fulcrum for all these muscles to help create motion. Then we have the sternoclavicular joint. It's the only direct attachment of the shoulder girdle to the trunk. It is formed by the articulation of the manubrium and the sternum and the medial clavicle. Okay, that clavicle serves as a muscle attachment and protection, prevent medial shoulder displacement, and prevent inferior migration of that. So what does that mean? So this clavicle will stop this elevation because it's attached here, right? So it helps stop any upward rotation because this joint is going to touch itself, or anterior rotation. Back here, it's going to stop it from moving this way or tilting off too far because this acromion and this clavicle are going to touch each other and stop that. Okay. And that inferior migration, that's going down through the ligaments that kind of hold that in place as well, right here. Then you have muscles on top that attach that. So you would see, once we add the muscles, it'll make more sense. And you see the lines of pull because you have a lot of soft tissue up here. You look where these bones are, and you see that there's a lot of space here. And if you look at someone like who does a lot of weightlifting, you'll see that there's a lot of muscular tissue that attaches at the skull on the vertebrae and then into the scapula so that it can stabilize that. It is a synovial joint at the SC joints. This is what the sternoclavicular joint is called in short, is the SC. So at the sternum and the clavicle, right here in the front, it's a synovial joint, so it's wrapped in a capsule. It has a little disc, and it's filled with synovial fluid. Okay, that's what helps lubricate the movement of those joints. The ends of the bone are covered in hyaline cartilage that we've discussed before. Like I said, it has a fibrous disc. The joint is diarthrodial because of the free motion that is allowed within it. And increased stability or increased motion of the clavicle leads to decreased stability. Okay, I forgot to put increased movement, mobility equals decreased stability. That's why you often get one of the big issues you could have is that bone just dislocating right out of there. You don't see much on top, right? You don't see much holding that down. And if you palpate that, you don't have many muscles attaching to that. So as that allows that elevation and depression, you lift your shoulder up, right? And you're getting a lot of motion out of that. What isn't happening is, I just realized I moved my border, sorry. What isn't happening is this move, so you can hold that and feel that as you move that, right? And you can see how a very violent contact or a very violent movement there could cause some pain within that joint as it loses some of that stability. It's triaxial, so it has 3 planes of motion. It protracts and retracts, so forward and back, right? It elevates and depresses, goes up and down, and then it rotates like that, okay? The movement is classified in terms of the direction the clavicle moves. Then we move on to the AC joint. If you look at the AC joint over here on the left, you see that it's mainly supported through ligaments, especially this acromioclavicular ligament and this coracoacromial ligament. And those kind of help keep that onto the coracoid and the acromion, and then the clavicle and the acromion. This acromioclavicular ligament really supports this joint here the most and keeps it within contact. What happens is if you get a violent force from the top here, it pushes down on the acromion and the clavicle, and it'll actually tear this ligament, thus creating an upwards mobility of that clavicle in what we call a piano key sign, where that clavicle is risen up now, and it stays that way until that ligament heals. And even after it heals, you still get a bump right on your shoulder right here. We might see some of you guys in lab with that. So the AC joint connects the acromion and scapula to the lateral clavicle. Most of the movement is between the clavicle and the scapula, and it supports high axial loads, so a lot of pulling up and down on this. It's a synovial joint, just like the sternoclavicular joint, and it's triaxial, so it has three ways of motion, right? So we have protraction and retraction, elevation, depression, and then rotation as well. Most of the motion occurs through the scapula. So the scapula is what really moves, not so much the clavicle. It is supported by those ligaments I just discussed, and overall it's a fairly weak joint because it doesn't have a lot of muscle there. So if you feel your AC joint, there's not a lot of muscle there, it's fairly exposed. So when you fall on an outstretched arm or you take a direct blow to the joint, often you will injure those ligaments. Then we have the glenohumeral joint. The glenohumeral joint offers the most range of motion of all the joints in the body. If we look back at our anatomy man, right, you see that it's not very stable in terms of bony articulations, right? So it's just that little glenoid sitting there and the humeral head. So we have very little bony restrictions through there, so it would offer a lot of range of motion. The convex humeral head and the concave glenoid fossa kind of move about each other. The glenoid fossa is only about 1/4 of the size of that humeral head, if you recall here, so you can see how small it is, right? If we're talking about overall surface area. And only about 25 to 30% of the contact at any given time is made between the humeral head and the glenoid fossa, so it only is really sitting on about 25–30% of that bone-on-bone articulation. And it's held in place within 1 to 2 meters 1 to 2 millimeters of the center of that glenoid fossa by mostly muscular attachments. So muscles really help stabilize that humeral head on that glenoid fossa. We always talk about it in terms of how it's like a golf ball on a golf tee, right? That's the best analogy because you have a very small surface area of that golf tee touching a very small surface area of the golf ball. It also works off the concave and convex roll. And then the glenoid labrum is a piece of articular cartilage. You can see it here in this picture. It's the yellow circle. And that helps just give some more depth to that glenoid to help increase contact to about 75%. So now you're getting about 75% contact between the glenoid and the humerus. So that's why tearing that labrum creates such increased instability in that shoulder girdle, because now I've lost some of that 75%. Now I'm back down to maybe 50% if I've lost some of that wall. There's 4 groups of motion that occur at the shoulder girdle. We have flexion and extension, AB and adduction. We have medial rotation and lateral rotation. And then we have horizontal abduction and horizontal adduction. Flexion would be when we lift our arm overhead, and that is about 165 to 180 degrees normal. Extension would be with our arm straight down by our side near our pocket, and that's only 0 degrees. Now when you keep going back and push your arm further back, you get about 30 to 60 degrees. So that's more here, right? So this is extension, right there, 30 to 60 degrees depending on the person. Abduction is lifting my arm like this, right? 150 to 180 degrees. Adduction, when I bring my arm back down, that's 0 because our thigh gets in the way. External rotation is where I open my arm like this, right there. External rotate, you think here, this humeral head is going that way as I move it out, right? Trying to get in the video there, right? So that's 60 to 90 degrees, and then internal rotation will be back towards my belly, and that's 60 to 90 degrees as well. Total rotational arc, so if I took from fully externally rotated to fully internally rotated, is typically between 120 and 80 degrees, 180 degrees, sorry. Horizontal adduction, so when I bring my arm here to here, right, I'm looking at about 135 degrees. And then horizontal abduction is about 45 degrees. Scaption is where you lift your arm in the plane of the scapula, so then the scapula is kind of how it sits in neutral position, and this kind of holds that in that position there, and that is where the scapular plane is about 30 degrees of forward flexion in the coronal plane. So from out to the side, about 30 degrees. That's what puts me there. We'll feel that as we get into lab portion. We'll really define that. It has a normal, firm end feel within the shoulder. All these motions do. Then we have what's called the scapular rhythm. The scapular rhythm is how the shoulder complex moves as one unit. So very few times does just a glenohumeral joint move, or just a sternoclavicular joint move, or the acromioclavicular joint move, or the scapulothoracic joint move. Many times it's often multiple movements within, or multiple joints creating one movement. So let's look at just shoulder flexion or shoulder abduction. If you look at that, the first 30 degrees of the shoulder joint flexion and abduction happens at the glenohumeral joint. So just those first 30 degrees. After that, and then also in the first 30 degrees of abduction, in the first 45 to 60 degrees of flexion, the scapula moves more in a stabilization position. So it might move closer to the spinal column, or it might move just a little bit away from the spinal column to put that scapula and that glenoid in the most appropriate and stable position available for the movement you're asking it to do. And it depends on different things such as muscular strength, injury to the labrum, ligamentous strength as well. So it's really unique to each person, and you kind of play around and feel people, and that's how you put your hands on them and feel how their scapula is moving during those motions. And that's how you really start to develop an understanding of what's actually happening within each individual. After 30 degrees of abduction, for every 5 degrees of flexion or abduction, the glenohumeral joint, the scapula upward rotates 4 degrees. So you can see, so it's a ratio of 5 to 4. So after 30 degrees, for every 5 degrees of flexion or abduction, the scapula upwards rotates. So it starts to move up like that. And we'll really dive into all this if you are a little confused in our lab. That's why the lab is very important during this part of the class. To achieve a full 180 degrees, the glenohumeral joint will move about 120 degrees and the scapula will move about 60 degrees. So then together, they're able to create that full 180 motion, 80-degree motion. And the clavicle must also rotate up in flexion and in abduction. So that is the end of section 1 here, where we're going over the bony anatomy. Next, we're going to go over the soft tissue anatomy and dive into that. So I'll see you guys in a little bit. Take care and be well.